Okay, we're going to begin our lecture on fluid and electrolyte acid-base imbalances. Water is a major component of the body. It's found both in and out of the cells. Water is the medium in which the metabolic reactions and other processes take place. It's also the main transportation system for the body. For example, water can carry nutrients to the cells, remove waste, transport enzymes and digestive secretions, move blood cells around the body. Without adequate fluid, cells cannot continue to function and death would result. Fluid also helps with the movement of body parts, lubricating things like the joints and the lungs. Our major components of the body is water. It is essential for homeostasis. It is a place for metabolic reactions, transportation system for the body, and helps with the movement of those body parts. So it regulates fluid volume. It's a buffer for the blood. It helps maintain temperature, cell shape. There are water and solutes mixed in with it. It's found in the cells, in the vascular area, in the interstitial spaces. And the major organs work together to help maintain the proper fluid balance. Body fluids can be discussed in terms of their specific fluid compartment. These compartments are separate from one another with some sort of form of physical barrier. The intracellular fluid compartment is the system that includes all the fluid enclosed by the cells, and the extracellular fluid surrounds all cells in the body. Extracellular fluid has two primary constituents, the component of the blood called plasma, and the interstitial fluid that surrounds all the cells but is not in the blood. Extracellular fluid also contains intravascular fluid or blood, interstitial fluid or intercellular fluid, cerebrospinal fluid, and transcellular fluids that are located in things like around the heart or the joints. About 60% of a male's body consists of water, the weight of his body. About 50% of the female and the infant's body is about 70% water. In the older adult, we see a decrease to about 45%. And it's that increase in water for the infant and that decrease for the older adult that place them at higher risk for things like dehydration. Suggests several functions performed by water in the body and the significance of each. So water in the body helps maintain body temperature through diaphoresis or sweating. It removes waste through urine formation. It helps protect and cushion the brain and the fetus. It lubricates and cushions the joints. It transports nutrients and waste. And it maintains pressure in the eye. The amount of water entering the body should equal the amount of water exiting. Intake and outtake must be equal. Fluid is added to the body through ingestion of solid food and fluids and as a product of cell metabolism. Fluid is lost in the urine and the feces, as well as through insensible losses, like in the skin or through perspiration or exhaled air. Water constantly circulates in the body, moving between the compartments. For example, cerebral spinal fluid will continuously circulate through the blood and then it's reabsorbed back into general circulation. A large volume of water is present in the digestive secretions entering the stomach and the small intestine, and that fluid is reabsorbed in the colon, making it very efficient watering recycling system. Which body compartment contains the most water? And why would diarrhea cause a fluid deficit more rapidly than coughing or sneezing with a cold? So the extracellular compartment contains the most water. That's the fluid inside the cells. There's about 3 trillion of them. Okay, and so that's where most of the water in the body is contained. Diarrhea would be more of a large loss of fluid, and when we have a large volume of fluid, that's lost with diarrhea. We also would lose electrolytes and proteins, and that can also affect the volume of fluid in the body. Where with coughing and sneezing, just a small volume of water or sodium would be lost. So these are just some of the sources of where we get our liquids from. So we get them from liquids, solid foods, and metabolism of the cell, and then we lose it through urine, feces, and insensible skin losses or through the lungs. Again, if you look at the totals, they just about equal each other. Osmoreceptors in the hypothalamus are triggered by our thirst mechanism, and that would promote the intake of fluid when we need it if it's working correctly. The antidiuretic hormone also controls how much fluid is leaving the body through our urine. It helps to promote reabsorption of water into the blood from the kidneys. Aldosterone is another hormone, and it helps conserve fluid by helping us retain or reabsorb sodium and water, and it helps increase our pressure whenever we have a fluid deficit in the body. The atrial natriuretic peptide and B-natriuretic peptide, these are hormones released by the cardiac muscle fibers, and they're in response to increased pressure or what we call the cardiac stretch. So as this fluid is returned to the heart, if there's excessive fluid there, it's going to cause those chambers to stretch. And as they stretch, these peptides pop out, and they will go and trigger the brain and start the process through the kidneys of eliminating water and sodium in the urine to prevent salt-induced hypertension. The atrial natriuretic peptide is synthesized and released by the myocardial cells in the atrium of the heart, and it helps reduce the workload on the heart. Whenever we have a diseased heart, we never want to increase the workload of it. So that's going to help keep us in homeostasis if it's working to reduce that workload of the heart by regulating the fluid, the sodium, and the potassium. The atrial natriuretic peptide can also increase the glomerular filtration rate, altering pressure on the capillaries in the kidney, and that can help reduce the reabsorption of sodium by inhibiting the production of the antidiuretic hormone. Renin secretion is also reduced, and the renin-angiotensin system is then inhibited. Fluid is then lost from the extracellular compartment, and the blood pressure would be decreased. So this is just some important things that you want to remember. The antidiuretic hormone is going to help us conserve water. The more we release, the more it's going to conserve. So it's also going to stimulate our thirst center. Aldosterone is going to control the absorption of sodium and water. And also it controls the loss of potassium. The natriuretic peptide, AMP and BMP, help reduce thirst and block the release of ADH and aldosterone. So when we have too much fluid in the system, this is going to help us decrease increase our urine output to decrease our blood pressure or that excessive fluid that's coming back to the heart to help reduce the workload of the heart. All right, fluid is going to constantly circulate throughout the body, and depending on the permeability of the membranes, how it's going to fluctuate between the compartments. The primary force driving fluid transport between the capillary and the tissues is hydrostatic pressure. And this is defined as the pressure of any fluid enclosed in a space that is exerted by the blood. So this pressure is being exerted by the blood, okay, within the blood vessels or the heart chambers. And it's exerted against the wall of the capillary. All right. And it's that force, that pushing force, that is driving the fluid out of the capillaries and into the tissues. So this is known, hydrostatic pressure is known as the push force. The osmotic pressure is the pressure that drives reabsorption. So the movement of the fluid from the interstitial fluid back into the capillaries is called osmotic pressure. And hydrostatic pressure is going to push fluid out, while osmotic pressure draws or pulls the fluid back in. At the arteriolar end of the capillary, the blood hydrostatic pressure or blood pressure exceeds the opposing interstitial hydrostatic pressure. And the osmotic pressure of the blood is going to move out from the capillary. So it's either pushed out of the capillary into the interstitial space. At the venous end of the capillary, the hydrostatic pressure is decreased and the osmotic pressure is higher. Therefore, the fluid is going to be pulled back into the capillary. It's easy to remember this if you think of the movements and oxygen out of the arterial blood towards the cells and the flow of waste and carbon dioxide from the cell back into the venous blood. Excess fluid and any protein in the interstitial compartment are returned to circulation through lymphatic capillaries. A major factor in the movement of water through the cell membranes is the difference in osmotic pressure between the cell and the interstitial fluids. As the relative concentration of electrolytes in the interstitial fluid and the extracellular fluid change, the osmotic pressure will also change, causing the water to move across the cell membrane by osmosis. So homeostatic mechanisms respond to changes in extracellular fluid, and they respond to changes in the plasma or the osmotic concentrations. Water movement between extracellular and intracellular fluid moves passively in response to that osmotic gradient. If the extracellular fluid is hypertonic or concentrated relative to the ICF, then the water is going to move from the ICF to the ECF. If the ECF becomes more hypotonic or less concentrated relative to the ICF, then the matter will move from the ECF into the cells. With edema, we have excessive fluid and it occurs in the extracellular areas. And it can be referred to as isotonic, hypotonic, or hypertonic, depending on the cause. The osmolarity or the concentration of the solute affects the fluid shift between the compartments of all cells. Edema occurs when we have excessive fluid in the interstitial compartment, and it's causing swelling or enlargement of the tissues there. It can be localized to one area or generalized throughout the body. Edema may be highly visible or invisible, or it may not accurately reflect the amount of fluid that's hidden in the actual area. For example, facial edema is more visible, but edema of the liver or limb may not be as visible. Edema is often more severe in dependent areas of the body because the force of gravity is greater there. So that would be areas like the sacrum, the buttocks, the ankles, or the feet of a person in a wheelchair. Drugs can also cause fluid to be trapped in the interstitial fluid. Drugs can also be trapped in the interstitial fluid with this edema. So edema has 4 general causes. The first one that we're going to talk about is increased capillary hydrostatic pressure, and that stops the return of fluid from the interstitial compartment to the venous end of the capillary, or it forces excessive amounts of fluids out of the capillaries into the tissue, like in cases of pulmonary edema. So in left-sided heart failure, that excessive pressure is forcing that fluid from the heart and into the tissues of the lung, causing that pulmonary edema. We see an increased blood volume and excessive pressure that could force fluid into the alveoli, interfering with the respiratory function. And this could be a life-threatening experience for someone that has left-sided heart failure and suddenly develops this pulmonary edema. Edema can also be related to the loss of plasma proteins, things like albumin. Albumin is like a water magnet, and it helps to keep the water or hold the water in the vessel. So whenever we have a decrease in the albumin levels, then we can see a decrease in the osmotic pressure. And the presence of fewer plasma proteins in a capillary will allow more fluid to leave that capillary and less fluid to return to the venous end of the capillary. Protein can also be lost in the urine because of kidney disease, and synthesis of protein may be impaired in some clients that have things like malnutrition or malabsorption or liver disease. Protein levels can drop also in patients that have acute burns or large areas of burned skin, patients with large open areas of impaired skin, and just losing the skin barrier itself, allowing protein to leak out of the body. These issues can cause excessive sodium levels in the extracellular fluid. When sodium is retained, it promotes accumulation of fluid in the interstitial space, increasing osmotic pressure, decreasing return of fluid to the blood. The blood volume and the blood pressure are usually elevated as well. And then we may see things like high sodium levels in clients that have things like heart failure, high blood pressure issues, kidney problems, or increased aldosterone secretion. Specific causes related to increased hydrostatic pressure include increased blood volume or hypervolemia associated with kidney failure, pregnancy, congestive heart failure, administration of excessive fluids. In pregnancy, the uterus can compress the pelvic when mom is sitting down, and when the pregnant woman has to stand for long periods of time, pressure in the leg veins can become elevated, causing edema in the legs and the feet. In congestive heart failure, the blood is not easily able to return back through the veins to the heart, and that can increase the hydrostatic pressure in the legs, the abdominal organs, and lead to things like ascites or fluid in the abdominal cavity. Edema can also occur from obstruction of the lymph circulation system, and that causes localized edema because we have excessive fluid and protein that are not being returned to the general circulation. This can happen if a tumor or infection develops and damages a lymph node, or if lymph nodes are removed because of cancer or through surgical procedures. Increased capillary permeability can cause localized edema and can result from an inflammatory response or infection. Histamine and other chemicals released from the cells following a tissue injury tend to cause increased capillary permeability and increased fluid movement into those interstitial areas. A general increase in capillary permeability can occur with some bacterial toxins or some of the larger burned wounds, and this can lead to both hypovolemia and shock. Local swelling may be visible, and it may cause the area of the skin to be pale or red in color depending on the cause. Pitting edema typically occurs in the presence of excess interstitial fluid. A depression or pit remains after the finger is removed. The fluid is moved aside when a pressure is applied by the finger. With generalized edema, there's significant increase in body weight, and this can indicate a problem before there are other visible signs. So we want to look at that weight. 1 pint of fluid is equivalent to approximately 1 pound. So this is just a picture. On the left, you see edema. On the right, you see the indentations from the finger where they pressed on it and they form that pitting edema. Functional impairment can occur, for example, if it restricts the range of the joint movement. Edema of the interstitial wall can interfere with digestion and absorption And edema around the heart or lungs impairs the movement and function because around there you have like the pericardial sacs, or the sac around the lung, and what that sac is doing is helping that organ to glide and move to decrease friction. Too much edema around any one of those areas could prevent movement of either the heart, which could lead to something called cardiac tamponade, or the lungs, impairing the person's ability to breathe. When we have edema, pain can also occur, especially if the edema puts pressure on the nerves, like in patients with cerebral edema. Pain on the nerves can cause headaches. Some cerebral edema can impair brain function because of pressure and ischemia and lead to death. When the kidney or liver is edematous, if the capsule of that organ is stretched, that can lead to pain. With sustained edema, circulation of the arteries may also be impaired. Increased interstitial pressure can restrict the flow of the arteries into the area and prevent fluid shifts that are carrying nutrients into the cells, preventing normal cell function and reproduction. And as a result, we would see things like either tissue necrosis or development of ulcers. Also, if a person has varicose veins in the legs, severe varicose veins can become large or dilated, and they'll have high hydrostatic pressure. And these veins can cause things like fatigue, skin breakdown, varicose ulcers that don't heal, and they can become problematic because of the insufficient blood supply going to that area. And in the mouth, if tissues are swollen, someone needs anything like dentures, they won't be able to fit them. It's going to be difficult. Sores can develop that are slow to heal and become infected because blood flow is impaired to the gingival tissue. Edematous tissue in the skin is at risk for breakdown from pressure, abrasion, and external chemicals. That skin's usually very delicate, so we need proper care there. And also, we have to be cautious because sometimes patients can injure themselves there and not even feel it. All right, next is dehydration, and this is inadequate body fluid, and it's usually happening because we haven't had enough intake or we have some sort of excessive loss or a combination of both. Losses are more common with the extracellular fluid. Water can shift in the extracellular compartments. So, for example, fluid might be lost from the digestive tract because of vomiting. The water shifts from the vascular compartment to the digestive tract to replace what was lost. If the vomiting continues, then the fluid is eventually lost from the cells, and that would impair the function. This can be adjusted according to the person's age, body size, and condition, reminding you that the elderly and the infant are at greater risk because they don't have the significant fluid reserves required for the body to conserve and restore. Infants have a greater insensible loss because they have a larger proportionally body surface area and an increased need for water because they have much higher metabolism rate. The vascular compartment is rapidly depleted for an infant, so they can easily become hypovolemic, affecting the heart, the brain, and the kidneys, as well as decreased urine output. So we'll see less wet diapers. And then increased lethargy, dry mucous membranes. Sometimes they'll even cry and they can't produce tears. Water is lost, and it's often accompanied by a loss of electrolytes, sometimes proteins, depending on what the reason is why we're losing the water. For example, if we're sweating, then we may lose water and sodium chloride. These electrolyte losses can influence the balance of water significantly because electrolyte changes lead to osmotic pressure changes between the compartments. Electrolytes as well as fluids must be replaced to restore balance. In isotonic dehydration, we will see a loss of fluid and electrolytes. In hypotonic dehydration, we will see a loss of more electrolytes than water. In hypertonic dehydration, we'll see a loss of more fluid than electrolytes. Hypotonic and hypertonic dehydration can cause signs and symptoms of electrolyte imbalances and also influence the movement of water between intracellular and extracellular compartments. Hydrostatic pressure is especially important in governing the movement of water in the nephrons of the kidneys to ensure proper filtering of the blood to form urine. As hydrostatic pressure in the kidneys increases, the amount of water leaving the capillaries will also increase and more urine filtrate is formed. If hydrostatic pressure in the kidneys drops too low, as in dehydration, the function of the kidneys will be impaired. Less nitrogenous waste will be removed from the bloodstream. Extreme dehydration can result in kidney failure. So causes of dehydration include vomiting and diarrhea, both of which cause us to lose electrolytes and nutrients like glucose, as well as any sort of drainage or suction from the digestive system. Excessive sweating with the loss of sodium and water, diabetic ketoacidosis with loss of fluid, electrolytes, and glucose in the urine, insufficient water intake in an elderly or unconscious person, and use of concentrated formulas in an attempt to provide more nutrition to an infant. So these concentrated formulas will have less fluid in them, less water. So what will we see? Initially, dehydration involves a decrease in interstitial and intravascular fluids. So what we'll see is dry mucous membranes, decreased skin turgor or elasticity, lower blood pressure, weaker pulse, a feeling of fatigue, increased hematocrit, indicating higher proportion of red blood cells. So it's thicker, more blood cells compared to water. So higher hematocrit, decreasing mental function, confusion, loss of consciousness. And that will develop as the brain cells lose water and the function is lost. And then as we're checking, the best place, especially on the older adult, is to check the sternum and the forehead. So we're checking for what we call tensing. When you squeeze the skin, it should go right back to shape. If it stays in sort of a tent or it stays up and doesn't return back to its normal position, then we're looking at definitely some dehydration. So there you can see her pinching the skin to see if it's going to go back to its normal state. And you notice she's doing it up on the chest, the older adult, sternum, and forehead. All right, this is just comparing the different signs and symptoms as to what we would see in edema versus dehydration. I would definitely review these, look at your lab values. What's going to change here? What would you see? So the body's going to try to compensate for the loss of the fluid. First thing it's going to do is the osmoreceptors in the brain or the hypothalamus are going to, osmoreceptors are going to send a message, right, in the hypothalamus to increase that thirst. We may see an increase in heart rate and then constriction of the blood vessels, which is going to cause the skin to appear pale and cool. And then less urine, concentrating the urine, increasing the specific gravity, a renal vasoconstriction, and an increased secretion of ADH and aldosterone trying to conserve fluid here. So if we conserve the sodium and we conserve the fluid, right? The ADH will conserve the fluid. The aldosterone will conserve the fluid and the sodium. Third spacing. So with this, we have fluid shifting out of the blood into a body cavity or tissue where it's no longer available. Examples: peritonitis, inflammation and infection of the peritoneal membranes, burns. Until it's removed, the fluid will stay in the third space in the body, but it's not functional. We can't do anything with it. Weighing the patient will not reflect this shift in fluid distribution. So we have to rely on lab tests like hematocrit and electrolyte concentrations to identify the third spacing. In a client with burns, third spacing will be evident as edema will appear in the area of the wound. So this is telling you just about the different distribution of the major electrolytes, okay? And I would know the values of the electrolytes. All right. Maybe there's another chart, I believe, in your book that might have like the ranges, and those I would want to know. Mostly in the blood, that's what we look at. Fluid movement between the compartments, the hydrostatic pressure or the force that's exerted by the fluid against the wall causes movement of the fluid between the compartments. The hydrostatic pressure of blood is the pressure exerted by the blood against the wall of the blood vessel by the pumping action of the heart. In the capillaries, hydrostatic pressure is higher than the osmotic pressure. All right, and we have a constant pressure that is produced by the albumin at the arteriolar end of the capillary. The pressure forces plasma and nutrients out of the capillaries and into the surrounding tissues. Then the fluid and the cellular waste in the tissue will enter the capillaries at the venal end. That's where the hydrostatic pressure is lower than the osmotic pressure. So there they can enter back in, and the osmotic pressure is going to pull them back into there, okay? Whatever's left would be drained and go back into the lymph system, and it's returned back into circulation. Based on the information given previously on fluid excess and fluid deficit, describe 3 signs and symptoms of third spacing related to a large burn area. All right, the fluid deficit in the vascular compartment is indicated by a decrease in blood pressure, rapid weak pulse, and dizziness, whereas the excess interstitial fluid, third spacing in this case, would be indicated by edema in the affected area. All right, what's the difference between the cation and the anion? So the cation is a positive ion formed when an atom loses one or more electrons. Metals typically lose electrons and become cations. Some of the examples are sodium, magnesium, all right, and there's a few more. An anion is a negative ion formed when an atom gains one or more electrons. So these are usually non-metals, all right, fluoride, sulfide, anion. Sodium is the primary positively charged cation in extracellular fluid. Sodium diffusion occurs between the vascular and the interstitial fluid. Sodium transport across the cell membrane is controlled by the sodium-potassium pump or the active transport, resulting in sodium levels that are high in extracellular fluids and low in the cell. Sodium exists in the body primarily in the form of salts, sodium chloride and sodium bicarb. It's ingested through food and beverages. It's in almost everything we eat, and it's lost from the body through perspiration, urine, and feces. Sodium levels in the body are controlled by the kidneys mostly through the action of aldosterone, which remember is helping us retain sodium and water. Sodium maintains extracellular fluid through osmotic pressure and makes up about 90% of the solute in the extracellular fluid. It's essential for conduction of nerve impulses and muscle contractions. The role of sodium and potassium in conduction of an impulse is essential. So they're stimulating that impulse in the muscle contraction. Excessive sweating can result in low sodium levels if more sodium is lost than water, or if only water is used to replace the loss. If an individual loses more water than sodium in perspiration, the sodium level may be high. Hyponatremia is a sodium concentration below 135 to 145. So is the normal here. So below 135 milliequivalents. Sodium deficits can result from direct loss of sodium from the body or from excess water in the extracellular compartment, resulting in hemodilution. Common causes of hyponatremia are losses from excessive sweating, vomiting, or diarrhea. Use of certain diuretics, especially when combined with a low salt diet. Hormone imbalances, such as not enough aldosterone, adrenal insufficiency, excess ADH secretion. So someone has syndrome of inappropriate antidiuretic hormone secretion. Early chronic renal failure, excessive water intake. Low sodium levels cause fluid imbalances in the compartments and can lead to symptoms like fatigue, muscle cramps, abdominal discomfort or cramps, nausea, and vomiting. We'll see a decrease in the osmotic pressure of the extracellular fluid compartment. Fluid will shift into the cells. Hypovolemia and decreases in blood pressure, and then cerebral edema. That leads to things like confusion, headache, weakness, or seizures. And that's because the fluid is shifting into the cells. Low sodium levels will impair nerve conduction and result in fluid imbalances between the compartments. Again, manifestations include fatigue, muscle cramps, abdominal discomfort, or cramps with nausea and vomiting. Low sodium impairs nerve conduction, results in fluid imbalances between the compartments. A high fever is likely to cause deep, rapid respirations, excessive perspiration, and a high metabolic rate. How would this affect the fluid and electrolyte imbalance in the body? Also lists several reasons why drinking a fluid containing water, glucose, and electrolytes would be better than drinking tap water after vomiting. In the case of the high fever, how would the fluid and electrolyte balance in the body be affected? Fluid loss would occur with hyperventilation and perspiration. Sodium loss and sweat also affects osmotic pressure of extracellular fluid and fluid balance. A higher metabolic rate requires increased turnover of fluid. So why would we drink something with electrolytes in it versus just plain water? Electrolytes can help replace the sodium that's lost, restore better balance in the body. Water alone is going to further dilute the electrolytes in the extracellular fluid, decrease the osmotic pressure, and lead to further fluid shifts in the body. Glucose provides nutrients for the cells with a higher metabolic rate, reducing the risk of acidosis. Hypernatremia is excessive sodium in the blood and the extracellular fluids. So here we have the greater than 145 milliequivalents. Excessive sodium results from ingestion of large amounts of sodium without adequate water intake or from a loss of water in the body that is going out quicker than the loss of sodium. So like diabetes insipidus, we might see this in. Specific causes include the following: insufficient ADH, which contributes to that large volume of dilute urine or diabetes insipidus, loss of the thirst mechanism itself, watery diarrhea, or prolonged periods of rapid respiration. Effects of hypernatremia would be a fluid shift out of the cells, and this is due to increased osmotic pressure of the interstitial or extracellular fluid, manifested by weakness, agitation, firm subcutaneous tissue, increased thirst with dry, rough mucous membranes, decreased urine output because ADH is being secreted. Manifestations can change depending on the cause of the problem. If the cause of hypernatremia is fluid loss caused by lack of ADH, then the urine output would be high. Compare the effects of aldosterone with those of antidiuretic hormone on serum sodium levels. List signs and symptoms common to both hypo and hypernatremia, and also signs that differentiate the two states. And then explain how sodium imbalances can affect cardiac function. Aldosterone would likely increase the sodium level or maintain a normal value if an equivalent amount of water is added. The total amount of sodium in the body would increase. ADH would decrease sodium levels because increased water reabsorption reduces concentration of sodium. Signs and symptoms common to both hyponatremia and hypernatremia, and differences. So signs that occur in both include restlessness, weakness, confusion, and convulsions. Hyponatremia is indicated by abdominal cramps, nausea, and diarrhea. Hypernatremia causes thirst, dry mucosa, oliguria, and increased body temperature. Hypernatremia resulting from increased sodium in the body also leads to edema, weight gain, and increased blood pressure. Hyponatremia caused by loss of sodium leads to hypovolemia. The signs depend on the cause and the relative change in the body water balance. How does sodium imbalances affect cardiac function? Sodium imbalances reduce the contractility and the strength of myocardium, leading to decreased cardiac output. Changes in fluid volumes will affect blood pressure, placing greater demands or an increased workload on the heart. So here are your signs and symptoms. This chart is from your book. I would pay very close attention to all the charts in your books. They like to ask questions from these charts. Make sure you look at them, know the signs and symptoms. What would you expect to see? What is the cause? Why is this occurring? Potassium is a major intracellular cation. Serum levels are low if it falls below 3.5. All right, so it should be 3.5 to 5 MEQs. Potassium is taken in through foods and excreted mostly in the urine under the direction of the aldosterone. Foods high in potassium include things like bananas, citrus, tomatoes, lentils, and then also we could, if we needed to, give potassium chloride as a supplement in a tablet. Insulin helps move the potassium into the cell. Potassium levels are influenced by acid-base balance. Acidosis can cause the potassium to shift out of the cell into the extracellular fluid. Alkalosis causes more potassium to move into the cell. With acidosis, we have a lot of hydrogen ions, and they come from the blood into the interstitial fluid because of the high hydrogen ion concentration in the blood. When the hydrogen ions move into the cell, they displace the potassium. Excess potassium in the interstitial fluid will go into the blood, causing hyperkalemia. The reverse process occurs with alkalosis. Acidosis also promotes hydrogen ion excretion through the kidneys and retention of potassium in the body. Potassium regulates intracellular fluid volume. It plays a role in several metabolic processes within the cell. It's also important in nerve conduction and muscle contraction of all types, determining the membrane potential. Abnormal potassium levels, both high and low, can have serious effects on contractions of cardiac muscles, causing changes in electrocardiograms, causing cardiac arrhythmias, and ultimately cardiac arrest. Here are some signs that we would expect to see with low or high potassium. The role of sodium and potassium ions in the conduction of an impulse are important because they work together to stimulate that conduction so that impulse can actually occur. Hypokalemia occurs when we have a potassium level less than 0.5. Causes are things like excessive losses from the body because of diarrhea, diuresis from certain diuretics like furosemide. Patients with heart disease that are being treated may have to increase their potassium in food or take a potassium supplement because if they're also on something called digoxin, then that can increase their risk for toxicity when they take either digoxin or one of these digitalis preparations. The presence of excessive aldosterone or glucocorticoids in the body can occur. And that can cause also low potassium levels, and they'll develop something called Cushing's syndrome. Now, remember, a syndrome is a collection of symptoms. So, in Cushing's syndrome, they have many of the symptoms that are close to or similar to Cushing's disease. And so, the glucocorticoids have some mineralocorticoid activity that promotes retention of sodium and excretion of potassium. And that's what actually leads to this condition. The decreased dietary intake, which may occur with alcoholism, eating disorders, or some sort of starvation, and then treatment of diabetic ketoacidosis with insulin, because as we give the insulin, it causes the potassium that had originally left the cell to now move back into the cell. So all of these things, the glucocorticoids, the dietary intake, the treatment of diabetic ketoacidosis with insulin, the diarrhea, the diuretics, they all can lead to this hypokalemic episode. What will we see in these clients? We would see cardiac dysrhythmias. We would see changes on the EKG pattern, prolonged repolarization, and this can lead to cardiac arrest. It interferes with neuromuscular function, and the muscles become less responsive to the stimuli, so they can become weak and fatigued. It usually starts in the legs and moves its way up. Paresthesias, so a feeling of pins and needles. We'll also see decreased digestive motility, decreased appetite and nausea. So the GI tract isn't moving as quickly, it's slowed down, and they're not as hungry. In people with severe potassium deficit, the respiratory muscles will become weak, and eventually it will lead to shallow respirations. And in severe cases, kidney function can become impaired, leading to the kidney's inability to concentrate the urine and increase urine output or polyuria. In the case of hyperkalemia, we usually have a potassium level greater than 5. Causes this include kidney failure because the body's not able to release the acids or the potassium, deficit of aldosterone, so we don't have enough aldosterone in the system, use of potassium sparing diuretics, so this would be like spironolactone, and these prevent potassium from being excreted. And then in addition to that, your patient might be on like an ACE inhibitor, and that may be causing them to retain the potassium. Leakage of intracellular potassium into the extracellular fluid. So we see this with anybody with extensive tissue damage. So any sort of crush injury, like something falls on them, something heavy, or any kind of extensive burns. And then displacement of potassium from the cells by prolonged or severe acidosis. Again, the role of sodium and potassium ions in the conduction of an impulse is important. The nerve is more easily stimulated because the ions can move freely across the membrane. So those work together to stimulate those muscle contractions. Other things that can happen from the hyperkalemia, we have cardiac dysrhythmias that can move towards cardiac arrest. We have muscle weakness that can progress to paralysis as the hyperkalemia advances and impair their neuromuscular activity. Then we have fatigue, nausea, and paresthesia. So compare manifestations of hyponatremia and hypokalemia, and also why is any small change in potassium considered a serious problem? All right, so hyponatremia causes movement or shift of water into the cells, causing muscle cramps, weakness, fatigue, abdominal cramps, and nausea. Increased intracellular fluid in the nervous system causes lethargy, confusion, and headache. Hypokalemia causes muscle weakness, paresthesias, nausea, abdominal distension, and decreased bowel sounds. Hypokalemia also causes serious cardiac arrhythmias, polyuria, and metabolic alkalosis. Small changes in the potassium are a problem because primarily potassium is an intracellular ion. Normal range is very low. Any change in the content has a significant effect. Both hyper or hypokalemia can cause cardiac dysrhythmias and cardiac arrest. Again, this is the chart with the different symptoms between hypo and hyper. I would pay close attention to it and know the levels. All right, calcium. Calcium is an important extracellular cation. It's ingested in food, especially milk, stored in the bone, and excreted through the urine and the feces. The balance of the calcium is controlled by the parathyroid hormone and calcitonin. It's also influenced by consumption of vitamin D and phosphate. So low blood calcium levels stimulate the secretion of the parathyroid hormone, which will increase bone reabsorption, causing release of calcium and phosphate into circulation. Increases in the formation of the dihydroxycholecalciferol in the kidneys will help increase the absorption of calcium and phosphate by the intestines and decrease excretion of the calcium and increase phosphate excretion by the kidneys. Vitamin D may be ingested or synthesized in the skin in the presence of ultraviolet rays, but that has to be activated in the kidneys. The vitamin D promotes calcium movement from the bone and intestines into the blood. Some people that live in climates that lack exposure to the sun can have reduced levels of vitamin D. Also, sun blocking agents with a high protective factor greater than 15 can reduce the amount of vitamin D synthesis in the body. Calcium and phosphate in the extracellular fluid have an inverse relationship. All right, so if calcium levels go up, the phosphate is going to go down. If the levels of both calcium and phosphate rise, crystals of calcium phosphate would precipitate in the soft tissue. Alkalosis can decrease the number of free calcium ions, causing hypocalcemia. Calcium has a lot of important functions in the body. It provides structural strength for the bones and the teeth. The calcium maintains the stability of the nerve membrane, controlling the permeability and excitability needed for nerve conduction. The calcium is required for muscle contractions, including those of the heart. And calcium is necessary for metabolic or enzyme reactions in the body, especially those involved in blood clotting. In hypocalcemia, the level is below 4 milliequivalents. I would know that. Causes of hypocalcemia include the following: hypoparathyroidism, decreased parathyroid hormones resulting in decreased intestinal calcium absorption, malabsorption syndrome resulting in decreased intestinal absorption of vitamin D or calcium, decreased albumin levels, increased pH levels, resulting in alkalosis. In kidney failure, hypocalcemia results from retention of phosphate, which causes the loss of calcium because of that inverse relationship. Also, vitamin D is not activated, thereby decreasing the intestinal absorption of the calcium. The increase in permeability and excitability of nerve membranes leads to spontaneous stimulation of skeletal muscle, causing muscle twitching, carpopedal spasms, and hyperreflective reflexes. Severe calcium defects may result in laryngospasms obstructing the airway. Paresthesias are common, as are abdominal cramps. The Chavoke sign or spasm of the lip or the face when the face is tapped in front of the ear, and the Trousseau sign, carpal pedal spasms when the blood pressure cuff blocks circulation to the hand, both indicate low calcium levels. And tetany, also known as skeletal muscle spasms, can cause prolonged contractions or cramps. Heart contractions become weak because of insufficient calcium for the action that it has on the heart, and conduction is delayed. Arrhythmias can develop and the blood pressure can drop. The effects of hypocalcemia on skeletal muscle and cardiac muscle differ. With skeletal muscle, we'll see spasms because of increased irritability of the nerve associated with the muscle fiber. With the heart muscle, we'll see weaker contractions of the cardiac muscle is directly related to the deficit of the calcium. Adequate calcium is stored in the skeletal muscle cells to provide for contractions, whereas contraction of cardiac muscles relies on available extracellular calcium passing through the calcium channels. Hypercalcemia is calcium greater than 5 MEQs or milliequivalents. I would know that. Causes of hypercalcemia. Excessive serum levels of calcium frequently result from the following: uncontrolled release of calcium from the bones because of tumors. Malignant bone tumors can directly destroy the bone, and some tumors, such as bronchogenic carcinoma, can secrete parathyroid hormone in excess needs of the body. Hyperparathyroidism can cause excessive calcium levels. Immobility can cause excessive calcium levels. We need weight-bearing exercises in order to distribute the calcium to the bones. Without the mobility, we have decreased stress on the bone, and this causes demineralization of the bones. Increased intake of calcium due to either excessive vitamin D or excess dietary calcium. Again, calcium is very hard to get out of the bones. So we don't want to take too much of the vitamin D or too much of the calcium. And then milk alkali syndrome associated with increased milk and acid intake can also elevate the calcium levels. High calcium levels will depress the neuromuscular activity and cause muscle weakness, loss of muscle tone, lethargy, stupor, personality changes. We'll see anorexia and nausea. High calcium levels also interfere with the function of antidiuretic hormone, resulting in less absorption of water and increase in urination, known as polyuria. If hypercalcemia is severe, the blood pressure will drop or the blood volume will drop, and the kidney function will decrease. The nitrogenous waste will start to accumulate, and the person can develop cardiac arrest. Cardiac contractions increase in strength, and dysrhythmias can develop. If excessive parathyroid hormone is the cause, bone density would be decreased, and spontaneous pathological fractures can occur, particularly in the weight-bearing areas, causing bone pain. If intake of calcium is high, the parathyroid hormone levels will be low, and more calcium will be stored in the bone, maintaining the bone strength. These are some signs of calcium imbalances. Again, I would know this chart and I would know the levels in milliequivalents of my different lab values, like, calcium, sodium, magnesium, chloride, potassium. Explain the different effects of low serum calcium on skeletal muscle and cardiac muscle. Hypocalcemia increases neuroexcitability, causing skeletal muscle spasms. Calcium is stored in skeletal muscle, therefore, it is readily available for muscle contraction. Contraction of cardiac muscle depends on movement of calcium from the blood into the muscle fibers. Therefore, hypocalcemia results in weak cardiac contraction and arrhythmias. Nerves are not involved in cardiac contraction. Describe the effect of each of the following conditions on the serum calcium levels and on bone density. Hyperparathyroidism draws calcium from the bone and stores the increasing calcium levels from the bone, stores increasing serum calcium levels and reducing bone density. Renal failure results in decreased active vitamin D. Therefore, there's less absorption of calcium from the intestines and the renal tubes, causing a low serum calcium level. Also, phosphate is retained in a patient with renal failure, and that will increase the phosphate levels and cause the calcium levels to drop because of the inverse relationship. Hypocalcemia stimulates increased secretion of the parathyroid hormone, leading to decreased bone density. And then excessive intake of vitamin D causes hypercalcemia and increased bone density. Magnesium imbalances. Magnesium is an intracellular ion that has normal value of 0.7 to 1.1 mmols per liter. About 50% of the total body magnesium is stored in bone. Magnesium levels are linked to potassium and calcium levels. Magnesium is found in green vegetables, and it's important in enzyme reactions as well as protein and DNA synthesis. Imbalances in magnesium are very rare. Hypomagnesemia results from malabsorption or malnutrition, and we often see it in clients that have chronic alcoholism because sometimes they fail to eat and they'll drink their milks. Causes of hypomagnesemia include use of diuretics, diabetic ketoacidosis, hyperparathyroidism, hyperaldosteronism. The effects of hypomagnesemia: neuromuscular hyperirritability, tremors or chorea, and these are like involuntary repetitive movement of the hands, insomnia, personality changes, increased heart rate with arrhythmia. Hypermagnesemia. Causes of hypermagnesemia usually occur with renal failure. Effects of the hypermagnesemia would be depressed neuromuscular function, decreased reflexes, lethargy, and cardiac arrhythmias. Phosphate imbalances. Phosphate is located primarily in the bone, but it does enter both extra and intracellular fluids. The level is normally 0.85 to 1.45 mmOls per liter. Phosphate is important in many metabolic processes, especially those involving the cellular energy source. Adenotriphosphate, or ADP, is made from phosphate. Bone and tooth mineralization is supported by phosphate. As the phosphate buffer system for acid-base balance and in the removal of hydrogen ions from the body through the kidneys. As an integral part of the cell membrane, it has an inverse relationship with calcium. Causes of hypophosphatemia are malabsorption, diarrhea, excessive use of antacids, alkalosis, hyperparathyroidism. Effects of hypophosphatemia would be tremors, weak reflexes, paresthesias, confusion, stupor, anorexia, difficulty in swallowing, and less effective function of the blood cells. So we see a decrease in the ability of the body to transport oxygen for our clotting and for the phagocytosis process. Causes of hyperphosphatemia usually result from renal failure. So dialysis patients will take the phosphate binders. And remember, again, that's going to affect their calcium level because of that inverse relationship. Tissue damage or damage from chemo. Effects of hyperphosphatemia would be manifestations of, would be the same hyperphosphatemia as those of hypocalcemia. So look at your signs and symptoms for hypocalcemia, and that's what we would expect to see here. Hyperphosphatemia mimics hypocalcemia. Chloride imbalance. Chloride is the major extracellular anion with a normal level of 98 to 106 mmols per liter. Chloride tends to follow sodium because of the attraction between the electrical charges on the ions. So high sodium levels usually lead to high chloride levels. Chloride and bicarb, both negatively charged, can exchange places to help maintain acid-base balance. Chloride tends to follow sodium because of the attraction between the electrical charge on the ions. So high sodium levels usually lead to high chloride levels. Chloride and bicarb ions, both negatively charged, can exchange places to assist in maintaining acid-base balance. As bicarb ions are used up in binding with metabolic acids, chloride ions can diffuse out of the red blood cells to maintain the same number of negative ions in the blood. As the bicarb ions are used up, binding with those metabolic acids, chloride ions will diffuse out of the red blood cells into the serum to maintain the same number of negative ions in the blood. The reverse situation can also occur when chloride levels decrease and bicarb ions leave the red blood cells to maintain electrical neutrality. Low chloride levels lead to high serum bicarb or alkalosis. This situation is referred to as the chloride shift. Causes of hypocalcemia are associated with alkalosis in the early stages of vomiting when we're losing a lot of hydrochloric acid, excessive perspiration associated with a fever or strenuous labor on a hot day. And this can lead to hyponatremia or hypochloremia and dehydration. Effects of hypochloremia would be nausea, vomiting, diarrhea, muscle twitching, confusion, sleepiness. Causes of hyperchloremia would be excessive intake of sodium chloride, either orally or IV, or hypernatremia attributed to other causes. Effects of hyperkalemia would include edema and weight gain. And that concludes fluid and electrolytes. You'll see acid-base imbalance on a separate recording.